Respiratory compromise is a very important post-op safety issue for patients, especially for surgical patients in the post-anesthesia care unit and in the surgical wards. It actually consists of lack of oxygen, so the patient may have hypoxemia, less than 90%, respiratory rate 6 or 8 per minute, or elevation of carbon dioxide, hypercarbia, at 55 millimeter mercury or 60 millimeter mercury. The key finding of the study is that respiratory events are very common in the PACU. And essentially, capnography, continuous capnography in the PACU can detect adverse respiratory events 8 minutes earlier than the standard of care monitoring, which is oximetry. We did a meta-analysis of all the data in the literature, and there are 10 studies, 5 on continuous oximetry and 5 on actually continuous capnography. And continuous oximetry is about 15 times more likely to pick up respiratory event than nursing check every 4 hours. And if we do continuous capnography, it is 6 times more likely to pick up actually adverse respiratory event than oximetry. So we actually find that by having continuous capnography in the PACU, it actually enables us, maybe we can prevent adverse outcome. The key takeaway of the study is that the respiratory event can be detected 8 minutes earlier. I would like to actually introduce the carbon dioxide narcosis pattern of respiratory dysfunction. Essentially, you have decreased ventilation when patients have opioid-induced respiratory depression. And then the oxygen saturation would decrease, and the carbon dioxide level would increase. So if the patient is on room air, when the oxygen saturation decreases to 60 millimeter mercury, which is 90% oxygen saturation, the alveolar CO2 would increase to 65 millimeter mercury. However, if the patient is on oxygen therapy, when the alveolar oxygen saturation is decreased to 80 millimeter mercury, the patient can have carbon dioxide narcosis. The carbon dioxide level can be at 80 millimeter mercury. So we cannot detect hypoventilation very quickly if the patient is on oxygen therapy. I also would like to actually mention about the pattern of respiratory arrest in sleep apnea patients. So you can see here, the vertical axis is the millimeter mercury, and the patient does have repeated apneas, and then the patient have respiratory arousal, and the patient start to breathe again. And with the repeated apnea, the patient have decreased oxygen saturations, and the carbon dioxide level will increase. And eventually, the patient may have terminal apnea, termed apnea failure. And there is a term called lights out saturation, and it is the time of arousal arrest. It is postulated to be around 20 to 30%. So essentially, when the patient oxygen saturation decreases to such a low level, then the patient may eventually will have arousal arrest and then die.